miscellaneous topics here. First, the long QT syndrome. This was first described in the 1950s and is a problem with repolarization, recharging of the ventricles. It can occur in a couple of different forms. It can occur in a congenital form or an acquired form. The acquired is probably more common nowadays. The QT interval is different in girls versus boys. It separates out at puberty, with girls getting a little longer, boys getting a bit shorter. The shape of the T wave may indicate the type, whether it's type 1, type 2, type 3. We're not going to get into that too much. And in fact, I don't think it's always that clear, even if you have all the goods on it. Many different settings. The ones that we run into in our setting in the adult patient, most people will not have had a normal life with a congenital long QT. They would have had syncope, lightheadedness, something like that in their teenage years or early adulthood. So if you get somebody in their their 40s or 50s and they're starting to have a long QT interval, it's probably something we've done to them. And they might have a good gene and a bad gene. The bad gene if they were homozygous, they would have a very long QT interval, but the good gene saves them for a little while until you poison that good protein and block a good channel and reveal that they have altered repolarization reserve. The clinical significance of this ranges from just being a curiosity. Yeah, you've got a long QT, you ought to know about that. You ought to tell your doctor, hey, I've got a long QT interval, or I've got repolarization reserve problems. What's that? Says the family doc. And just make sure that all drugs that somebody wants to prescribe from you are checked with the qt.org, qtdrugs.org website. It's always being added to. I think I have that on a subsequent slide here. Or it could be very, very dangerous stuff, polymorphic VT that may be refractory, and you have to keep shocking these people until the drug's out. Acute therapy with magnesium. This is from the 80s or so. It's a little bit of voodoo stuff to it here. It's not really clear on a cellular level why that should work. It does not alter the QT interval, and it probably doesn't even really work. Probably it's tincture of time and the other stuff you're doing along with it. Magnesium takes the credit for it. It's not wrong to do. You're not going to cause too much problems with this, but I wouldn't say, okay, just give them some mag and don't call me until the morning. That's probably not going to work. Isoproterenol may be useful in many settings. It's an unusual thing. We tend to think of beta blockers for most ventricular arrhythmias, but isoproterenol can get you out of trouble, especially if it's a bradycardia, long QT, drug-related phenomenon. Temporary pacing may be even necessary. Here is a long QT ECG. It's a really unusual one in that not only is the QT mondo long, it's even hard to tell where this thing ends, but it is highly variable down in the rhythm strip here. This is QT, not really alternans because that's alternate beats, but QT flexibility or variability. This is a very, very dangerous situation where not only is the QT very long, but has this crazy business where it's not the same from beat to beat. These people are very vulnerable to polymorphic ventricular tachycardia. Moving on to the Brugada syndrome. You will run into this more often nowadays than we had thought before. This was first described in the 1990s by the Brugada brothers from Europe, Spain and the Netherlands. And this is a problem with repolarization, early repolarization, not delayed repolarization, but early repolarization in some cells in the right ventricular outflow tract. What they're doing there, why this occurs, not too clear, but is characterized by an upwards coved ST segment, and typically in V1 and V2. And if you're suspecting it and not seeing it in the leads that you have, move the leads up and enter space, and you might see it a little bit better. It sort of looks like a funny right bundle branch block, but right bundle branch block has another manifestation in deep S waves in leads 1 and AVL and V6. And you don't see that with the Brugada pattern. It's just over the right ventricular outflow tract leads. The settings for this are the congenital problem, somebody that's born with this and may manifest it differently at different times. Some ECGs normal, some not so normal. But this can be brought out by fever challenging these channels somewhat, or sodium channel blockers such as flecainide. That's not an ICU drug most typically, but people may come into the hospital already taking that drug. Procainamide can also do it. No, don't use that too often either. But fever is a very common situation where this pops up. And we get all tangled up. Here's an 80-year-old who's had a cholecystectomy. He's doing fine. Somehow he got to be 80 years old without any problems. And now he's got Brugada sign on his ECG. Should we put in a defibrillator on this guy? Probably not. Probably treat his fever with acetaminophen. That might work as well. Not a very common antiarrhythmic drug, but it works in some cases. This, again, ranges from insignificant, just something you need to avoid certain drugs or situations you need to treat fever very aggressively when it occurs, to sudden onset ventricular fibrillation. Those are pretty polar opposites from insignificant to very significant. Acute therapy, treat the fever. Quinidine, what in the world? We don't use quinidine too much anymore, but this is a very good drug for this because it blocks the channel that's responsible for this early repolarization, the transient outward current, the ITO. Longer-term therapy with a defibrillator in people who've had a cardiac arrest, sometimes ablation of sites in the right ventricular outflow tract. This is still a little bit controversial, very little data on that. Now there's real Brugada and there's fake Brugada. One of my friends, Andrew Cron in British Columbia, says it's kind of like beer. There's real beer, which is the real type 1. This is this upcoved, upwards concave or convex up pattern here in V1 and V2. And then there's light beer, which is this saddle pattern here. It's where it's scooped upwards here in V1 and V2. These people are not really Brugadas. They're sort of, you can convert them into that with flecainide or another agent like that or severe fever. But they are typically not going to have much rhythm problems. And then there's people who have the so-called type 3 pattern, which is different. It's just a tiny bit of ST elevation in V1, and that's no beer at all. So there's real beer, light beer, and no beer. So there's that ST segment there in V1 and V2. Now, we'll move on from that to devices and pacemakers and defibrillators. There's a lot of verbiage out here that we throw around that we think everybody knows, but maybe not everybody knows that sort of stuff. Many years ago, the pacemaker code was cracked and came up with this designation here. The first letter when you're talking about a pacemaker is the chamber or chambers that are paced. This can be atrial, this can be ventricular, it can be dual, or it can just be single. A device is handed off by a pacemaker representative. There's a single chamber pacemaker. You might use it in the atrium, might use it in the ventricle. So that's why it's just designated S here. The second letters of chambers or chambers sensed, that can be atrium, ventricle, or dual. The third letter is how it responds to sensed events. So it can be inhibited, it can be triggered, or it can be both inhibited and triggered. So you might have a pacemaker that senses the atrium, it paces the ventricle, and it triggers its ventricular pacing based on a atrial event. So that would be a VAT pacing mode. We don't program that way anymore, but it's part of the functionality of a DDD pacemaker, where it paces both chambers, capable of pacing both chambers, capable of sensing in both chambers, and capable of being inhibited by events that it sees, as well as being triggered to respond to an atrial rate. And the fourth letter is a rate response if present. There's a fifth letter out there as well for tachy response. We don't ever use that. So for instance, a VVIR pacemaker is a ventricular pacing, ventricular sensing, and inhibited by a spontaneous ventricular event, and it paces more rapidly in response to perceived physiologic need. A DDD pacemaker paces and senses in both atrium and ventricle, and is both triggered and inhibited. It's the most common programmed mode. Implantable defibrillators, or ICDs, now there is a brand, Boston Scientific has a brand called the Automatic Implantable Cardioverter Defibrillator, AICD. That's a brand name, so if somebody has a different manufacturer's device, it's just an ICD. There are single chambers, dual chambers, and now we used to call it a single chamber an SCICD. Well, now there's a subcutaneous ICD, so people call that a SQ or an SC. That causes some confusion, but now one manufacturer makes a subcutaneous with no leads inside the heart, with some particular advantages there. Biventricular stimulation is possible nowadays, and as a cardiac resynchronization therapy device, they can be both pacemakers or a pacemaker pacing function in a defibrillator can. So a lot of different possibilities here. Interpreting paced rhythms is a science. It is really difficult to get this right sometimes, and identifying true pacemaker spikes used to be a little bit difficult. It's even more difficult, I think, nowadays, because your telemetry systems, Holter systems, and so forth, if you designate, click that this patient has a pacemaker, whenever the monitoring system sees things of a certain frequency response, it says, must be a pacing spike, and it puts in the thing on the monitor like it's real. It may be real, it may not be real. Usually they get those right, but sometimes it's a little funny. So it's important to identify true pacing spikes, try to figure out which chamber is getting the spikes, and figure out what mode of pacing and pacing rate the thing is set for, if that's possible. It's important to try to figure out if capture is present, if it's consistent, if sensing is present, and if it's consistent. And if you are in trouble and just can't figure out what's going on, most patients will have a card on them that designates what manufacturer they have. Sometimes you can look on an x-ray, chest x-ray. If they've already had one, I wouldn't get a chest x-ray to get this information. But if they have an x-ray, sometimes you'll see a little designation on it that'll identify what the pacemaker manufacturer is. And then there are these 800 numbers to call for. These are the major manufacturers we deal with. Generally speaking, unless there's been some trauma to a device or it's a very, very old device, they usually work pretty well. And so any funny business you see on a rhythm is probably some variation of normal function. That is a good starting point for analysis of these things, but you need to prove that that's true. So here's a chest x-ray that tells a couple of things here. This is a pacemaker. It's a relatively small can here. And, let me go back here. Relatively small can and a relatively thin wire to it that doesn't have any extra stuff on it. This is a larger can and has a wire that's a little bit thicker than this one and has some extra stuff on it. 2 coils. These are shocking coils here. Now, if you're just looking at one of these, you can't say, well, what's large and what's small? It's hard to tell. But typically the shocking coils and the large size of a can are pretty good clues here what's going on. Here's a paced rhythm here. This is sinus rhythm with tracked right ventricular pacing. This is how I interpret this along the way. And you see a couple of things here. One is you see a single pacemaker spike prior to a QRS complex, consistent capture here. There's a P wave in front of every QRS that you can see along here in lead 2, most particularly. And you see that the pacing spikes are of different amplitude and vector along the way here. Some of these are pretty large and some of them are not so large. Here in lead 2, up, kind of down. What's that all about? Well, this is when it has to do with the frequency, the short duration of the pacing spike and the sampling frequency of the digital ECG recorder. It catches it either going as the pulse is going up or as the pulse is going down on the output of the stimulus, and so that it's not that the wire is moving around in the heart. It's just a funny business about how the thing is recorded. Here's atrioventricular pacing in a patient with a dual chamber pacemaker, and you see not too much over here, but in the inferior lead you see an atrial pacing spike followed by a P wave, a ventricular pacing spike followed by a QRS. Nice consistent capture all the way. And you can say furthermore, this is right ventricular pacing, because if we look at V1, it's going down. It looks like a left bundle branch block. It's a leftwards axis. It's negative in the inferior lead, so it's coming from the bottom of the heart, from the right ventricle, and on the right side. So it is probably right ventricular apical pacing, not a bad guess in this situation. Another thing you see is that there are volts going away from almost all the precordial leads, suggesting that it's a pretty apical location. Everything's kind of lining up that way. Here's somebody with a biventricular pacing system. And the things to note here are that with a single chamber single ventricle being paced, it's a relatively wide QRS because we're pacing one side, not going through the his Purkinje system, going muscle to muscle. Here we're capturing both ventricles simultaneously, so you get a narrower QRS. That's part of the aim of this. And quite often it has a little bit of a right bundle pattern because we're pacing LV first and RV a little bit after that. You can adjust the timing on these things. And it gives a rightwards axis because it's left ventricular first. So this is a sinus rhythm here, and it picks up the P wave, transmits it back to the pacing system, puts out an impulse, LV first, a few milliseconds later, the RV, so you have this nice narrow QRS. And somebody had a very wide QRS to begin with. All right, troubleshooting. You'll be called on by your nurses to say, you know, this guy has a pacer, it's not working, why don't we see this? There are two major categories of this. Why don't I see ventricular pacing? That might be because you don't see any spikes at all, or you see spikes but they don't capture. Of this first category, you got a dead battery. That's my problem. I should have followed up the patient a little bit better than that. Or the pacemaker is programmed to go at a slower rate than the prevailing rate. And if you say, hey, the rate's 60, why isn't this pacing? Well, maybe it's programmed to go at 50. It's not going to pace at 60. If it's programmed to pace at 70, you better see some spikes. You may also have oversensing. It may be programmed to pace at a certain rate. You're seeing it going lower than that rate, but it is inhibited by something it's seeing. For instance, myopotentials. This is not too often seen in the hospitalized patient because they're not moving around so much. But a lead fracture can also cause a make-break noise on the lead and make it look to the pacing system like there is a QRS complex when there really isn't. Second category, spikes are present but they don't capture. Either the pacing threshold is increased above your output level. This may be because of acidosis. That's not common in the ICU, is it? Ischemia, drug electrolyte stuff, hyperkalemia, and a problem that I have occasionally, fibrosis at the lead tip. It just is harder to get the impulse through. Or the lead has become dislodged. This is really uncommon in somebody who's had a device for more than a few weeks even. We fix this thing in place, but if we go in with a Swan-Ganz catheter, pulmonary artery catheter, or sometimes even a PICC line, you can dislodge a lead that's not been in there for very long. Now, here is a patient who is not sensing very well, so that's why it's called non-sense. And you see a bunch of pacing spikes along here. There's one here, there's one here. That should not be there. That's in the T wave or just after the T wave. This is really bad stuff here. So it's just kind of walking along here. This is acting as though it's not sensing anything. It's the so-called VOO mode. It's pacing in the ventricle, but it's not sensing anything, and it's not inhibited or triggered by anything. And this is probably a pacemaker who is just about at the end of life and is not capable of doing much of anything except giving what it senses as its last gasp of life-saving output to keep the patient from dying. And in fact, it's just not doing much good at all. So there are those spikes along there. Some of them capture. They certainly don't sense. Now, magnet use can be very handy for you. I think every ICU should have one of these donut magnets hanging around. It's nice to know where it is, not just that it's there. Nice to know where you can grab it if necessary. Pacemakers and ICDs respond differently to a magnet over them. Pacemakers uniformly will respond with a fixed rate without any sensing. So if you've got somebody who you don't know if they're over-sensing something, then you can just slap a magnet on it and it'll start pacing anyway, and you can see whether the thing is even capable of responding, whether the battery's dead or anything else. It's not sensing any rhythm, and so you may end up inducing atrial fibrillation or some short episodes of VT with poorly sensed or non-sensed complexes. A magnet over an ICD doesn't do anything to its pacing function. All it does is blind it to sensing ventricular arrhythmias. So it's handy if somebody's getting repeated shocks due to a lead fracture. They're doing fine. They're not having any actual arrhythmias, but a lead fracture is causing artifact and fake sensing of arrhythmias, and they're getting repeated shocks for that. You slap a magnet on it, that will stop as long as the magnet's in place. That's about the only application for that. Now, implanted devices do just fine on their own, but when you get somebody in an ICU, it's a dangerous place for them. They get electromagnetic interference, they get electrocautery, they get MRIs that can alter function. Increasingly, these devices are savvy to that, and in probably the next 10 years, it just won't be an issue anymore. But CTs are not a problem. Plain röntgenography is not a problem either. Lead dislodgement can occur in a relatively recently placed device with a PA catheter that you're just having a great deal of difficulty getting out the PA. Lots of in and out with the catheter can dislodge a lead. Pretty unusual. External shocks can cause devices problems, but most typically only if you use like paddles and are right over the device itself or right over the lead. They have shunt circuits in them to protect the electronics of the device from voltage coming back through the antenna of the lead, so that is typically not too much of a problem. But one way or another, place your pads at some distance from the actual implanted device. That's usually not too much of a problem. There may be a temporary increase in the pacing threshold that causes a little bit of pant soilage by the people watching this go on, but it's a transient phenomenon. It goes away in just a few seconds, most typically. Transcutaneous pacing. It is feasible but flawed. It uses current applied across the chest through typically defibrillation-like patches. I have actually captured atrium through these things before, and not ventricle. You can capture both, and ventricle in some cases, but also captures skeletal muscle and causes jerking. It's not very pleasant to have, a lot of ECG artifact, and difficult to tell when you're capturing. So you need to get a pulse somewhere to see whether you really are capturing on intravascular tracing is better because of so much jerking, and you better sedate the patient so you won't make too many friends. Transvenous pacing can cause some problems with hematoma, arterial stick. If you're inadvertent, we just had one of those the other day. It was, when you pulled out the sheath, it was spurting. Okay, what was that all about? Didn't know about that problem. Sometimes you'll have a persistent left superior vena cava coming in from the left subclavian, and it takes a very funny course. It goes into the coronary sinus. It's difficult to get into the ventricle that way. You have to kind of make a loop-to-loop. We don't like to see that too often. Lead stability may be difficult. You're relying on this to pace the patient, and it may not be all that reliable, especially from the femoral approach. You can perforate the heart. That is signaled by a high threshold and or chest wall or diaphragmatic stimulation, pain of which the patient complains, or a pericardial effusion. They've already got enough problems being under your care with what caused them to be under your care, and they don't really need this on top of it. A poorly sensing temporary pacing system can occasionally cause VT or VF. This is usually in a peri-infarct setting, severe ischemia, not much else. Infection at access site ports. If you're not careful about that, and you say, okay, the patient needs a permanent device, and you get them down to the EP lab for it, and they've got this soupy-looking thing where they had their temporary lead, that's not too pleasant. So here's somebody coming along here with, they had an inferior infarct and had transient Wenckebach and were doing pretty well, but somebody decided to be a hero and put in a temporary pacing system. And along about whenever this is, this is 9 in the evening. This is many years ago. Don't see this too often nowadays. We have this pacemaker that's capturing sometimes, but not all the time. It's certainly not sensing very well. And here we have an R on T and ventricular fibrillation. And yeah, like I say, this is 15 years old. I don't see this very often. We don't put in temporary pacemakers in this setting. It's a very unusual phenomenon. So don't get too vexed about it, but it is poor form to have a poorly sensing temporary device when you have the possibility of sensing correctly. Now, cardioversion. Generally speaking, lower energy is better for most cases. 20 joules, even 5 joules, even 2 joules may work for atrial flutter or ventricular tachycardia. It should be synchronized when you're trying to cardiovert a uniform, a monomorphic rhythm. Each shock does its thing, and then the device again devolves to asynchronous mode in case it were ventricular fibrillation, or in case you are shocking VT and it goes to VF. So you have to manually resynchronize to avoid shocking on a T wave. For defibrillation, a higher energy is used. Only for ventricular fibrillation is it not synchronized. You don't want to be waiting for a sync signal on VF. It's very low amplitude. For atrial fibrillation, I like to use anteroposterior, or this kind of right peristernal and left scapular. It gets the atria across that vector. For VF, anteroposterior, anterolateral is just fine for that. Now, so here we have the good, the bad, and the ugly. This is coming along for atrial fibrillation up here. Sync, cardiovert, sinus rhythm, everything's great. That was a big hero day there. This is not so good. Here's somebody with ventricular tachycardia. Here's a shock that is not particularly well synced. It is on the beginning of the T wave, and we get ventricular fibrillation out of it. and then another shock comes along, and boy, aren't you glad I saved your life today? Well, you shouldn't have done that in the first place. Should have worked better. All right, question number 1 here. A 55-year-old woman says she's had a single-chamber pacemaker, and what kind of pacemaker is it? But particularly, what is it doing? Is it normal atrial sensing and capture? Is it normal atrial sensing but not good atrial capture? Abnormal atrial sensing but normal atrial capture? Abnormal atrial sensing, abnormal atrial capture, or abnormal atrial sensing and normal ventricular capture? Many choices. Abnormal atrial sensing and abnormal capture. Yeah, now you got it here. So we have coming along here on our slides. With stimulus artifacts here, which chamber is involved here? Well, occasionally we'll see a stimulus followed by a P wave. We see that particularly right here, that QRS is earlier. There's a P wave after that stimulus. So this is an atrial pacemaker. So she says it's only got one chamber. It's got to be atrium. And it's working sometimes, but not all the time. Here's a stimulus that is not followed by a P wave. Another one over here not followed by a P wave. So it's not pacing all the time. And is it sensing all the time? Well, it should be inhibited by, it should know its own rate here. And let's see, here is a spontaneous P wave. It didn't capture with that one, spontaneous P wave. So it should have inhibited this output until the next cycle. And this is the paced rate that it's supposed to be. So this interval here, from here to here is right on normal, and it should be that interval starting here and going out to about there somewhere before we have another stimulus artifact. So it's neither sensing well nor pacing well. And so this lead has lots of problems. Yes? The answer was abnormal D. I think you all got that correct. Is it marked as B? Marked as C? No, it's abnormal both. I'm sorry about that. It helps if you have the correct answer designated, doesn't it? D as in dog, yes. Or it could be B as in bog, or C as in cog, but it's D as in dog. All right, next question here. Thank you for pointing that out. Okay, you've just placed a temporary transvenous wire from the right femoral vein in a patient with heart block and a slow ventricular escape. On fluoroscopy, everything looked good, but this ECG is recorded. What should you do now? Decrease the pacing output and repeat an ECG. Get a stat echo, order stat serum potassium level, or get another chest film. Okay, I'm not sure what A is going to do for you. That's a common reflex, or just pull back the catheter or something like that. The chest film you're going to get anyway, so that was not a very good distractor to put in here. What's going on here on our actual question form here? We have a stimulation that's capturing reliably here. It has a right bundle pattern and a right axis and a positive axis. Now, if you remember what right ventricular pacing looks like, it's kind of the opposite of that. Right ventricular apical pacing is left bundle, left axis, superior axis, coming all inverted or downward in the inferior leads. This is just the opposite of that. So maybe this is not right ventricular pacing after all, it's left ventricular pacing. And where is it pacing left ventricle? Well, how do you get to the left ventricle from the femoral vein? You've got a couple of choices. You can go through a patent foramen ovale, and then across the mitral valve. That happens. You can get into the coronary sinus now to coronary vein. Hey, you just did biventricular pacing. That's pretty smart. And both of those can look fine on fluoro. The one thing you really don't want to have is perforation of the right ventricle. and the lead is outpacing the epicardium in the left ventricle, and that's why you get an echocardiogram. That is the correct answer in this case. You might see the lead in the chambers on the echocardiogram, in which case you can reposition it or just anticoagulate if the patient is not in a way that they can be repositioned. But you really need to make sure that you're not perforated under those circumstances. I think this is my last slide here. Again, hospitalized patients have a lot of stuff that happens in supraventricular and ventricular arrhythmias. Getting a correct diagnosis is the start of correct therapy. And lots of different things that we can do for people. There are a lot of things that we do to people instead, and we need to make sure that we're doing for people.